Good morning, everyone, and a very warm welcome to all of you. On behalf of Team Neuroptech, thank you for joining us for today's live webinar. We're really glad to have students and practitioners from different places coming together to learn and grow as a clinical community. Today's session focuses on a topic that goes beyond just maps and machines. We often look at corneal ectasia through topography and tomography, but the clinical impact extends much further, especially when it comes to binocular vision, functional vision, and patient quality of life. So today, we'll be exploring seeing beyond maps, corneal ectasia, and its impact on binocular vision. This session is designed to help you connect structural corneal changes with real clinical symptoms and diagnosis. It is a pleasure to introduce our resource person for today's session, Mr. Pijush Sinha. He is a qualified optometrist with B Optome and M Optome and has completed advanced clinical training from FCLGEI. He currently works as a senior consultant optometrist and has over 4 years of hands-on clinical experience. But before we begin the session, here are some pointers for our attendees. Attendees are requested to please mute their mics and shut their cameras throughout the session. You can ask your questions in the chat box and we'll take them up once the session ends. Thank you for being with us today, sir. Over to you.
So am I audible to you, right?
Yes, sir.
Yeah, thank you for the kind introduction and good morning to all. It's a pleasure to have a chance to share my thoughts with you all. So let me share the screen first. My screen is visible to you, right? Yeah.
Yes, sir. Yes, sir.
Yeah. Let me put the laser mount. Okay, so good morning to all. My name is Pijush Kanti. I'm an optometrist and a vision therapist. So today I'm going to talk something that we often encounter but do not level it correctly. So often we get patients with corneal ectasia which is stable, but even after that, the patient gave complaints. So today we are going to understand what happened to binocular vision in patients with corneal ectasia, right? So this is why the title here given is Seeing Beyond Maps, Corneal Ectasia and its Impact on Binocular Vision. Let's start. So yeah, so whenever there is a talk on corneal ectasia, it is a corneal and which is leading to the increased fusion demand, continuous sensory motor compensation between these two, and ultimately it is leading to the fixation disparity. So this fixation disparity reflect the stress in the fusion system, not necessarily it is a any squint present. There is no squint present, but yeah, the fusion is disturbed here, and ultimately it is leading to the unstable binocular control. So yeah, so here you see in this picture a long-standing war going on between eye and the brain. Eyes are the affected eye is not producing good image. It is producing blurry, less contrast, distorted image every time. Brain is trying so hard to make it clear, but it is not happening. So ultimately, what lead to brain slowly start playing favorism. It do not give equal opportunity to both eye, and it prefer one eye more than the other, and it slowly ignoring the weaker eye, which is producing bad image. Ultimately, it is leading to the initial separation stage. That because after that the patient shift to a 2D world from a 3D world. So the stereopsis ability goes down slowly. So it is leading to compromised stereo equity and sensory suppression to prevent diplopia. But here directly don't the patient do not go to the sensory suppression. First it go to the intermittent suppression. So this is the binocular test that we need to do here in this kind of patient. Here the first most important step that we will take in patients with corneal ectasia, give the proper optimal optical correction. It can be in the form of glasses, contact lenses. I'm not a contact lens specialist. I'm a vision therapist, but yeah, I have little knowledge about contact lens also. But whenever I get patients with corneal ectasia, first of all, I refer to the patient to my contact lens specialist, and then after the patient got adapted with the contact lens, it can be soft toric or RGP, rose contact lens. There is a bunch of rose contact lenses are also there with scleral contact lens. After he get adapted with it, it can be the CXL also done with the patient. Then I call the patient for binocular assessment. The Hirschberg corneal reflex test is a very important one. It is not giving you the dioptrical value differences or measurement of the eye deviation, but yeah, it is giving you a subtle misalignment of the eye. What you need to do, like you need to use a torch light, put the light on here in this part, and you will see two light reflex in the center of the pupil. So you need to see the position of these two light reflex on the cornea pupil. If the light reflex are just inside the pupil, that means the eyes are properly aligned. But if there is a displacement of the light, like here it is forming outside, there is esotropia, inside there is exotropia, up there is hypertropia, and down it is hypotropia. If the position of the light is in between the pupillary margin and the limbal margin, it is 30-degree deviation. If it is in the limbal margin, that is here it is 15-degree and it is 30-degree limbal margin, and outside the limbus it is 45-degree or more than 45-degree. So this is how we will do the Hirschberg corneal reflex test. It's giving a gross assessment of the eye misalignment only. Cover test, very much important, where you need to do the direct cover test and cover uncover test. But I directly go for the cover uncover test while I close one eye and see the movement of the other eye. Here I'm looking at the tropia. If the uncover eye take up the fixation after I occlude the one eye, then there is a presence of tropia. Now, after holding the occluder for 1 to 2 seconds, then quickly move to the other eye. If you see that the eye that was undercover previously take up the fixation or movement, then you need to see the movement of that eye. So it indicates presence of phoria. So with this test, we can identify the presence of tropia and phoria both. So need to do the cover test properly. Then WFDT, Oat for Dead test, is very important in this kind of patient because long stenting corneal ectasia will lead to what I told you, intermittent suppression kind of thing. So here Watford dot test performed for both distance and near, distance at 4 meter, near at 40 centimeter distance with a torchlight where four color dots are there. Like patient is putting a red green glass, red in front of the right, green in front of the left. If the patient say that he is seeing four dot here, that indicate fusion is present. So here you the color of the white dot will depend on the dominancy of the eye. If the right eye is dominant, he will see this eye is more red. If the left is dominant, he will see this dot is more green. If the patient say that there is two red only and there is no green, that indicate left eye suppression. If only three green is there, no red, that is indicating right eye suppression. Here, this condition is not that much visible in corneal ectasia patient, but yeah, it might happen. So here it is an uncrossed diplopia that is seen in esodeviation, and it is cross diplopia that is seen in exodeviation. Also, the near point of accommodation, near point of convergence with RF ruler and flipper testing. So to see this is the Vergence flipper to measure the fusional reserve and also the flexibility of the Vergence. In near point of convergence, there is a line and a dot. You will move the target slowly and patient is seeing the line with both eye and instruct the patient to inform you that when the line become double. At the time, at a distance where the line become double, stop and measure the distance. There is a break point and move the target little back. And when these the separate line become a single again, that is the recovery point. So the normal range, it should be 10 or less than that in convergence. If it is more, and like here, the break point is 16 and recovery is 20, it indicates the convergence insufficiency kind of thing. It might happen in many times, like you are seeing a patient with corneal ectasia, that NPC value is normal, but when you do the flipper test, like here Vergence flipper, like 3 diopter base in, 12 base out, he is not able to clear the prisms properly. That indicate the flexibility is less. Even after convergence is good, flexibility is less. It lead to the fusional abnormality. So here you need to see that which prism patient is having more difficulty, whether it is a base in prism or base out prism. If the patient say that, most of the time happen in research article also say that, yeah, if the patient is having difficulty in base out prism clearance, or it take time, that patient will say now it is single but he need time to clear the base out, that indicate the convergence issue. So it is very important. So yeah, another thing, like flipper, the Virgin's flipper is done in both eye. For it is for both eye, but accommodative flipper done in monocularly and then binocularly. So this is the accommodative flipper with NRA PRA. Accommodative flipper to see the flexibility of accommodation, that how nicely the patient can change focus from a distant to near and near to distance. For examination purpose, remember this thing, that you should use plus minus 2 accommodative flipper for examination purpose. But when you are giving the therapy to the patient, don't start with plus minus 2. You can start with plus minus 1 or plus minus 1.5 to the patient. So the start from very basic, when wherever you are starting the vision therapy exercises. NRA PRA. NRA means how much patient can relax the accommodation. This is done both eye together, and you will put plus lenses in 0.5 diopter steps until the patient report first sustained blur, and so you will record it as a break point, right? And here PRA means how much patient can induce accommodation. In patients with corneal ectasia where fusion is disturbed because of the image mismatch or clarity difference in both eye. So here, most of the time, it is not a golden rule, but I found most of the patient having difficulty to clear both lenses. Here, accommodative infacility kind of condition happen in this kind of patients. Uh, and fusional reserve, you will check it with a prism bar. There is a vertical and horizontal prism bar, PFB and NFB, that you need to measure to see the fusional reserve. So here, what happened, that when a patient is with corneal ectasia having less accommodation ability, so it lead to the impact on the accommodative convergence or AC by A ratio. So ultimately, it is not because of the muscle imbalance, it is because of the sensory fusion anomaly. So ultimately, as accommodation is directly linked with the convergence, so convergence affected. So in this kind of patient, most of the cases we find the PFV is less than the NFB for near. And ultimately, the stereo acuity, you can test it with a Titmus fly or endot stereo test. Now let's go to the management of it. Yeah, first of all, the most important step of managing a patient is giving the patient proper optimal optical correction. It can be in the form of RGP, scleral, mini scleral, CXL, anything. Give the best correction, make the patient adapted to it, and then go for the vision therapy. Another important is like binocular. In if the patient is still complaining of eye strain, headache, and dizziness kind of thing, only by modifying his lifestyle, most of the time patient got symptom free. Like tell the patient to have proper lighting condition with proper back posture, proper break, like break like 20-20-20 rule. In every 20 minutes the patient need to take a break of 20 seconds, see distant object, or posture should be good, something. Even after that, if the symptom do not resolve, then you can go for the convergence kind of therapy. Here convergence therapy you can give, or vergence facility deficit, if there, then definitely you can go for the jump version exercise or base out flipper therapies. Now, before the patient develop the corneal ectasia kind of condition, they might having the compensated heterophoria. Compensated means there was presence of phoria, but as their fusional reserve was sufficient, so they can overcome that phoria and they were symptom free. But as there was corneal ectasia and their accommodation is continuously in work with a vergence instability, so the fusional reserve is continuously getting drained, and there is a lack of fusional reserve. So it ultimately lead to the failure of the shared criteria, and patient become asthenopic symptoms, headache, eye strain. So this is known as decompensated heterophoria. Means the phoria is no longer it is recovered. It is no, even after the phoria or the angle of deviation is very less, patient is not able to hold it properly, and it lead to symptoms. So here, the first give the patient proper optical correction. In it can be in the form of glasses or contact lenses, and then give the patient fusional vergence therapy. If you are giving therapy with a prism bar, then give the patient first step versions and then smooth versions. Step versions means suppose the patient is having difficulty in convergence, like in PFB, you will train it with base out prism. So here start. Suppose patient PFB value is about 10 is the break point, or 10 is the blur point, and then 15 is the break point, and again 13 is the recovery point. Okay, so here you just give first at 10 prism diopter base out, and then sudden jump to the 15, then some jump to the 20. There is a step versions, and so that the patient flexibility of the convergence will improve. Then after the flexibility improve, you can go for the smooth versions kind of therapy, so that there is a gradual improvement will be there. Yeah, for the versions you can give the Brock-string exercises also, or you can give accommodative flipper. That I prefer to give this versions therapy in office therapy with lifesaver card and barrel cards. These are also depend on the patient severity level, like how severe the patient is having corneal or vergence anomaly. So here most of the patient I see that they are or having difficulty to fuse these two circles together, and I need to continue this therapy for 2 weeks or 3 weeks, then going for the third step something. So it need a proper observation, so it is better to call the patient to office to give the therapy, not giving the this kit to home and then tell the patient to do it. So here the patient do not do properly. That's what I have seen. And this is the aperture rule. That is also quite very important tool to train the vergence instability, where we should not use this one in case of convergence related issue. We will use the single aperture, and here the plane of accommodation, and here the plane of convergence, right? So here the more the distance, that means the more there will be the convergence demand. So here it is working in that principle, and patient need to put some extra effort to fuse these two target together. So it's quite very impactful. So it is also an in-office therapy. After you give the patient here all the fusion related or convergence related, then go for the suppression management. Here first of all you need to give the anti-suppression therapy by anaglyph glasses. Contrast and luminance balancing therapy, there is lot of softwares also available, or there is red green bar chart or some charts also with less contrast. You can give it to the patient to improve the contrast as well as suppression. Yeah, and here binocular integration tasks like Brock-string and vectogram also work very well. And here dynamic anti-suppression there. I find this pegboard kind of therapy quite impactful in patients with suppression, where there is a motor fixed behind it, and this pegboard is in a rotating manner. So patient is using red green glass and having red and green pegs are there. Suppose you are telling the patient to insert the peg on this F, so he will see with this one with the left eye with the green filter. He will not see this one with the right filter. So he will use the green peg to put it here with the left eye. So we are dissociating two eye to work together, right? So that is where it is a very good way to treat suppression in patients. After that, yeah, stereopsis is the highest level of binocular vision, right? So once you give the proper management to the optical correction, then anti-suppression fusion, then stereopsis, we have seen there is a significant improvement. Even after that, if there is a no improvement in stereopsis, then there is a softwares also available, like here HTS. It can improve the stereopsis properly. Otherwise, we can use this vectogram with anaglyph glasses to improve the stereopsis also. Putting it all together, a stepwise clinical protocol here. First, confirm it's the case of corneal ectasia. So here you need to have a basic idea how to diagnose a case of corneal ectasia. You need to know that what are the signs of keratoconus. So there is a classical 7 signs of keratoconus is there, right? So in slit lamp, you might need to know that what are those 7 signs, and then give the patient proper optical correction, then evaluate the binocular vision status, where if there is any anomaly there, then properly address and give the management of it. Then stereopsis and fusional training, call the patient for both contact lens follow-up as well as the BV assessment. So the golden line, ectasia management is incomplete unless optical clarity and binocular stability are treated together. Yeah, there is a case from my clinic only. The patient was 24-year-old who was complaining of both a blurring of vision for distant near since 3 years with eye strain, headache difficulty with prolonged near activity. He was having progressive blurring of vision since 3 years and with frequent eye rubbing. And he was using glasses since 5 years, and PGP was 1 year old. You can see this was the previous glasses number, and there is significant increase in the current glasses. When I did the refraction, his visual acuity improved significantly to 6.9 from 6.18, but he was not happy with the correction, right? Because the cylindrical number was high, and there was, even after that, he was complaining of shadow or it is not comfortable. So what I preferred is, even after the visual acuity is good, you know what, I'm obsessed with 6 by 6 line. I don't know how much it is right or wrong, but if the patient is not able to read the last line, then I become very sad. Okay, no, why the patient is not reading the last line? It should not be there. But I'm actually very much obsessed. So I referred the patient for the contact lens practitioner, and they given the rose K contact lens to the patient. So here they given rose K contact lens. There is a for oval cone type of keratoconus. There is a range of rose K contact lenses like rose K NC for nipple cone keratoconus, rose K IC for irregular cornea, rose K2 PG, postcraft, rose K mini scleral contact lenses or soft contact lens, many other things. So don't go directly to, suppose you saw the patient is having keratoconus, directly you are jumping to the scleral contact lens. It should not be there. There is a step-by-step go to approach for the contact lenses. So when I refer the patient for the contact lens, the visual acuity becomes 6.6 in both eye. There's the pentacam where shows right eye having 52.4. There is more than 47.20 definitely, and the left eye 48. So right eye was having more severity than the left eye. Peki was also less. Progression index more than 1.20. That is abnormal. So both are having bilateral keratoconus, but right eye more severe than the left eye. This is the binocular vision status. After 2 weeks, I did the assessment when the patient was properly adapted with the contact lenses. He was happy, but he was then also complaining. So here, HBT was normal, CT was exophoria for near more than distance, and NPA was in normal range, but the NPC value was less. There is 14, where according to the age with uh, here his age is 24. Here NPC should be uh, 10. So but here it is 14, that is less. And whenever you get patient with convergence kind of insufficiency, the difference between the break and recovery is quite very high. You will get a difference of like 2 centimeter or 3 centimeter, or sorry, 4 centimeter something. So here break is 14, recovery is 16. Accommodative facility was less, here 8 cpm and 9, and he was having difficulty with plus, that indicate relaxation difficulty. Virgin's facility 8 and difficulty with base out, PFB was less and AP normal. NRA, PRA, both values are normal. It's supposed to be 2.5 to 3. So these two are less, and with right eye suppression in ortho dot test with stereopsis was also less. So the diagnosis was convergence insufficiency with accommodative instability. So here in this kind of patient, first accommodation instability happen, then a secondary to the accommodation convergence anomaly start. So the in management part, we given the patient vergence management with vergence management with Brock string. So after alongside we giving the Brock string, we given the jump convergence exercise to the patient. Where and then this is the accommodative flipper that we given. I didn't given this ±2, but yeah, I given +-1 for regular exercise. I call the patient for vectogram training with red green glasses and sensory fusion, and yeah, he was so happy after having the therapies properly, because the symptoms improved significantly, and he was not having that much symptoms right now. So it is a combined collaborative approach, giving the optical correction with lifestyle adjustment alongside checking the binocular stability. Also, don't forget to check the dry eye status, right? Sometime we often see patients with corneal ectasia, we given the optical correction, then BB assessment, then also they are giving complaints. So here, a simple dry eye assessment like TBUT test or Sharma test, OSDA scoring tells many things. And if any dry eye therapies, then definitely we can go for that one also. So it's a combined thing, right? Only seeing one part, it will not make a successful patient service, right? Thank you so much. And if anyone having question, yeah, we can take it.
Yeah, sure. Thank you so much, sir, for such a clear and clinically relevant session. Now it's the time for the Q&A session. Attendees, please drop your questions in the chat box and we'll take them up. Okay, sir, we have our very first question. May I take it?
Yeah.
Okay, so the question is, how do we treat diploma? I think diplopia. I think it's diplopia. How do we treat diplopia through orthoptic experience?
Okay, so as we talk about our case, that is corneal ectasia. So in this kind of cases, diplopia is most of the time it is because of the location of the cone. Suppose the cone is located inferiorly, it lead to the vertical kind of diplopia. So at that time, patient when we give the proper optical correction with contact lenses, the diplopia actually resolve. But even after that, if there is a the diplopia still persists, then definitely we need to do the diplopia charting. And if there is any muscle anomaly or paralytic kind of squint, then we need to treat accordingly, whether we can go for the prisms or we can go for the surgery.
Okay. We have another question. Would you prefer giving anti-suppression therapy first and then fusional therapy or the other way?
No, first of all, I will need to give the fusional kind of therapy side by side with anti-suppression therapy.
Okay. So if anyone has any doubt, now is your time. Please drop your question in the chat box. Let's give it a minute. Okay, yeah. So we have another question. The patient had suppression in F WFDT, word for dot test. How did you check stereopsis and fusional range?
Okay, so first of all, if we see this, there is a suppression, then definitely his stereopsis will be less. So if even after you do the Rendot test or Titmus flight test, his stereopsis will be less because his stereopsis is not good. So my first target is to treat the suppression alongside the fusional and then go for the testing. Like if here the patient having stereopsis, then first prefer to give the patients suppression treatment or management and then go for the evaluation again. Then we can go for the fusional kind.
Okay. In formifrostic keratoconus, which changes first? Curvature, elevation, or pachymetric spatial profile justify physiologically?
Okay, so for that we need to understand what is formophoste keratoconus actually. So in formophoste keratoconus, it is like suppose you are doing slit lamp examination. There is no clinical feature like here. There is no monsoon sign, Risuti sign, Fleischer ring, Bott striae. Nothing is there. There is no equine hydrops, and even you are not getting a scissoring reflex. In pentacam report, you will get subtle changes in the parameters. Like here, the where is the next up? Yeah, like here the difference between these two corresponding point is like 1.5 or 1.7, but other parameters are normal, so it is a suspected kind of keratoconus. So yeah, the keratoconus definitely start from the posterior surface to the anterior surface, but from a first keratoconus we need to take proper history, family history properly, and make a close observation. Need to repeat the pentacam report regularly in 3-month interval, and we can give them glasses where there is no need of giving contact lenses.
Okay. Sir, ectasia conditions only considered to keratoconus or other conditions as well?
Corneal ectasia is a broad term. It is an umbrella term. So here, as I show you one map here, like, so there is different shape. Normally in keratoconus, if someone having a normal corneal structure, you will get oval or symmetrical bow tie pattern. These are normal. But here, even after that, if someone having symmetrical bow tie pattern, that indicate the presence of astigmatism. So here, if there is a skewness also, you need to measure the angle of skewness. If it is more than 22, that means that is an ectasia case. So here keratoconus seen in round or round here, like here in nipple cone keratoconus, or inferior stiffening. Here you will get in pellucid marginal corneal degeneration. Superior stiffening, most of the time you will get in pterygium marginal degeneration, like butterfly, clap claw, or kissing dove type of pattern. These will be you will see in pellucid PMCD kind of condition, or keratoglobus, post-LASIK ectasia, all such things are there, right? So you have to think in such a way. Only keratoconus is not included in corneal ectasia. Other things are also there.
Okay, okay. So what are the uses of RAF ruler in accommodation and convergence?
Okay, so RF ruler, let me put the photo first. Yeah, so this is the RF ruler. It is having separate target for accommodation and convergence. So for convergence, it is going to tell you the what is the closest point where the patient can see an object single. So that is the convergence, right? So it is only telling you the near point of convergence. And for accommodation purpose, you will get the closest point where the patient is able to see the line or the letter clearly. So here, suppose in you are measuring NPA, or near point of accommodation. Patients say that he is seeing that line clear at 10 centimeter distance. So you need to calculate the amplitude of accommodation there. So how to do that? Like divide 100 divided by the NPA value, and you will get the amplitude of accommodation. If the more the age, the less will be the amplitude of accommodation. That means the patient will have more difficulty for near. So if suppose someone is having age 35 and his accommodation, the near point of accommodation is coming as 14 or 16, it is normal for their age range. But if even after that, the like his age is 36 and his NPC value is coming as 16 or 18, it is less, because convergence remains same throughout the life and accommodation changes. So this thing actually get information from RF ruler. It's very useful. Don't forget to put the best correction to the patient and then go for the test.
Okay, okay. So we have another question. Why is it necessary to correct suppression in corneal ectasia?
Okay, so yeah, as I told you earlier, that suppression correction is very important, because the patient, as suppression alter the patient depth perception. So yes, if you do not correct the suppression properly, then he will be living in a 2D world. So the depth perception, 3D perception will be less. So ultimately, he will have binocular anomaly also. So here, this is why correcting suppression is very important. Once you give the optical correction to the patient, his contrast might get improved little bit, but at the same day or within 2 to 3 days, suppression will not improve. That means his binocular vision is still under stress. So he will give you constant complaint of eye strain, headache, because there is a constant war going on between brain, muscle, mind, and eye, right? So here, to reduce this thing and to make the eye again functioning, so you need to give the suppression, because otherwise the suppression can lead to amblyopia as well.
Okay, okay. We have another question. If there is any other procedure to treat keratoconus other than CL if cornea is very thin?
Uh, so keratoconus management based on its stage of keratoconus. First of all, what I prefer is, if the patient corneal curvature is in between 48 or 49, not complaining that much, then I might prefer them with glasses. But with contact lens, thin cornea doesn't matter here. If the patient, suppose you call the patient for a follow-up visit today and you found the corneal pachymetry is about 300, in the next visit the corneal pachymetry become 280 or 260, there is a progressive thinning. So first of all, you need to prefer the corneal cross-linking to make the corneal progression stop and go for the contact lenses. Even after that, if the vision is not improving, then intact corneal intrastomal ring segments are important to make the stiffened cornea a little flatter. Go for the contact lens. Even after that, if it is not working, then definitely there is a corneal transplantation is there, like DALC procedure or full thickness corneal transplantations.
Okay, okay. Should we examine steropsis at last?
Yeah. Stereopsis, if you found that because of the corneal ectasia, many of the patient happen that with even after with the correction of with contact lenses, stereopsis may become in the range of 200 or 120 or 100 something, and it is not below 50. So after you give the fusional exercises with suppression management properly, the stereopsis automatically get improved because it is related with contrast and fusion or sensory fusion. So once it get improved, then stereopsis will also improve. So we need to make a close look at the improvement of stereopsis. So we need to measure this thing every time. It's not we are measuring it one time only. Like you are taking the visual acuity doing the comprehensive assessment, measure the contrast sensitivity stereopsis. There is a golden rule every time. So you need to follow this thing properly every day, every visit.
Okay, okay. Now I will take our very last question. How do tear film instability, eye movement, and Shimflak image reconstruction errors influence posterior elevation values?
Okay, so first of all, in Pentachem, there is not that much role in tear film instability. It is you are telling about the topography that is based on the placebo imaging technique. So I basically do not prefer topography. I prefer tomography. There is the Pentachem. So here, even after the cornea is having severe dryness, then also we can go for the pentachem. And yeah, I suppose I did the Simflux imaging or pentachem to one patient and found the Bellin Ambrosio map showing some yellow spot. I do not stop myself in only one reading. I take three reading to see whether it is correctly taken or not. Even after the QS value is okay, then after three reading, I confirm that which is the best and not showing the abnormality, because I also don't want patient to get sad. That's why. So need to three consecutive reading and go for the best one.
I'm not agree with your answer.
Okay. So what you said?
So basically, the posterior surface not directly measured,
Okay.
and इसका mechanism जो है सिंपली इमेज डिटेक्ट द एयर टेयर फिल्म इंटरफेस एज एंटीरियर बाउंड्री लाइक जैसे irregular breakup, uneven thickness, light scatter, incorrect anterior surface detection, edge localization error. So effect on posterior elevation like just because corneal thickness is calculated anterior surface posterior surface by tracing pachymetry become the inaccurate posterior surface reconstructive clinical जो आई मूवमेंट जो सर 2 मिनट दीजिए 2 मिनट 2 मिनट दीजिए सॉरी
Can you again repeat, please?
I don't know. I think something went wrong. We have another question by Annapurna. Refractive surgery is a corneal ectasia condition.
No, refractive surgery is a cosmetic procedure. Like for refractive surgery, first of all, we need to do the proper detailed, comprehensive eye examination where vision, refraction, cycloplegia, refraction, retina evaluation. Pentachem plays a vital role here. All the values should be same and normal. If any value is found to be abnormal, like here thickness is less, then ultimately the residual stromal bed thickness will be less. So it is quite contraindication that time. But here nowadays, advanced refractive surgery option like Silk Pro are there, where there is no flap created, only a small lenticular is taken out. But then also we consider 470, if the thickness is less than that, then it should not be a condition. And here we need to follow the surface ablation kind PRK kind of procedure. So it is not a corneal ectasia condition. It is a cosmetic surgery. But yeah, if the parameters are not judged earlier, then it might lead to corneal ectasia later.
Okay, okay. Thank you once again, sir, for sharing your time and clinical experience with us today. On behalf of Team Neuroptech, I would like to thank all the participants for attending and actively engaging in today's session. We hope this webinar helped you look at corneal ectasia not just as a corneal condition, but as something that significantly impacts binocular and functional vision. Now we are at the end of the session. Thank you to Adnan, our founder, and Asad, our co-founder, for building this platform and creating opportunities for learning and collaboration within the optometry community. And thank you to Arman, our administrator, for continuously shaping the vision of Neuroptic and supporting the growth of this community. I would like now to ask Arman, please drop in the QR. Attendees, please screenshot this and fill up the form so that you can receive your certificates. I'll give you a 30-second time for that. Okay, I think it must be done by now. Thank you once again to the entire Neuroptech team and everyone who joined us today. That's all for today. This is Shazia Shabir, your moderator, signing off.